United States. I'm not going to go through the biographies of our distinguished speakers. They're all in your program. But after each brief presentation, we will open the floor again for questions and comments. And we'll begin with Dr. Lein, who's the Dean and Professor of the School of Social Work at the University of Michigan. And her 30 years of research has concentrated on the interface between families in poverty and the institutions that serve them.
Thank you very much. Is this on? Let me try one more time.
Yes.
Wait, I have to talk louder and closer.
We seem to need you to have it right up by your lips.
I wanted to thank everyone for this wonderful occasion. Like some of the previous speakers, I was thinking these are hard acts to follow, but I think I'd rather phrase it as a really fabulous conversation with which to engage, and it's exciting to be here. In addition to being involved in social work for many decades, my training was as an anthropologist. And anthropologists, as you know, try to learn about what they're studying by living in communities, trying to spend long enough there so that they themselves experience some of the impact of the phenomena they're dealing with, and also so that people get to know them and talk with them. And so I want to start with work I began in San Antonio many years ago. Some of my colleagues here have heard about it before, and carry it through from older work to newer work, asking the question, what have we learned about healthcare and healthcare delivery from the standpoint of impoverished women and their families that should make us very careful as we look at the Affordable Care Act and what we want to get from it in the future. I first worked in San Antonio one summer several decades ago, living in a community on the near west side where my children, who were then 4, 8, and 12, and my husband joined me. And it was there that I looked at the experiences that families were having, and in particular, how healthcare was really entwined with housing, with education, with nutrition, and with the other issues that these families were facing. So in that first summer, we'd been there for several weeks, and we were living in a community center that was embedded in a public housing project. For those of you who know, in Texas, there was no air conditioning, so it was very hot, and it was very crowded. And furthermore, after I'd been there a couple weeks, I was calling back to a colleague to compare notes on an article he had written. And he asked where I was staying in San Antonio, and he said, and I explained, and he said, why, Laura, you're staying in one of my hot spots. Now, when an epidemiologist tells you that, you do want to inquire about what a hot spot is. And what he explained is he was doing research on areas in the urban United States, neighborhoods that had the health profiles more similar to those of developing countries than to those of the United States. And this area in San Antonio was one of his exemplar communities of that. So as we stayed there, and I settled in with my family, I'm going to tell you some other stories about it as I move forward. By the end of the summer, we realized that our family had developed that kind of health profile. And it had several lessons. So what did we have? People always want to know that. So my daughter was testing positive for exposure to tuberculosis. My son had, who's the young one, the 4-year-old, those of you who have been in the South know about fire ants, which are biting insects. When a young child or a young creature gets a bulk of bites, 40 or 50 bites, they become seriously and systemically ill, and they scar at the site of every bite. And so we didn't know at the time that in this community, fire ants had become inside pests. They lived in the walls, they lived in upholstered furniture, they weren't just outside. And someone had left a cookie in our laundry basket, and ants had swarmed into it under a sheet. When my son went in to help me do the laundry, they swarmed onto him. And so he developed this kind of a syndrome too. I'm not going to give you the whole litany, but we looked ill. by our own standards. And there were a couple of lessons for me in that. I didn't recognize it till we left because our family was just the same as all the other families we were living with. And I clearly had been incapable of preventing my family from becoming ill, even though I thought I was trying hard. And I think it's important to realize that that is the lot of a lot of mothers raising their children in impoverished communities that are facing those kinds of health issues, is they are community-wide issues. They're not just family or household issues. And there's not much you can do if you stay in that community to protect yourself or your children from becoming ill. A lot of what I took away from that is that it's easy to blame mothers, and my husband was with me, but these were in general single-parent families, for the health ills that befall them and their children. But in many cases, I don't understand how we could have prevented that except by leaving. These pests were in the walls. Tuberculosis, there was not a wholesale way to test. The community was paying for testing tuberculosis even though it was ripe, and so the exposure was likely to happen. And as Diane pointed out earlier, children's health is primarily in these impoverished single-parent families the mother's responsibility. And so their ill health becomes a responsibility of hers. A decade later, I came back. I was in and out of San Antonio, and then again was concentrating in the poor areas there as we did a study comparing 3 cities, but I'm going to concentrate on what I learned from San Antonio, and from the 75 families, a group of us tracked over 18 months. And for many of these families, stability across all their domains was the problem. They didn't always have health care insurance. They sometimes had health care insurance. However, only 3 or 4 of the 75 families had health insurance for all members of their household continuously over the period we studied with them. A child would lose it, the mother would lose it. Often they weren't even sure who had health insurance because it was flipping over so quickly. And while health insurance isn't a cure-all, it's certainly important. Furthermore, since neither of these things were stable, they ended up taking on a variety of kinds of fixes, which I'm going to get to in a minute. The health insurance they had access to also missed key conditions, what one of my colleagues refers to as the ENTLs: mental health, dental health, eye health. Families didn't have access to it, and we have appeared incapable of recognizing how much that lack of care to some families is a dilemma nationally. Just to give you an example from the ground, we interviewed one of the women who was explaining that she was very concerned about her vision, which was deteriorating rapidly, and she didn't have eye insurance. She was employed and did have insurance, but not eye insurance, and she couldn't afford the eye exam or the glasses that would almost certainly follow from the eye exam. Her employment, she was a school van driver, so she was driving children daily with this eye condition when she wasn't able to get served. And so I think to link again how these health conditions permeate the community in all kinds of ways. At the time, again before healthcare reform, even very low wages excluded adult women from care, even if their children were eligible. And that eligibility for their children and themselves fluctuated according to the hours they worked, the wages they earned, made a difference in whether they had insurance and what kind of insurance. Particularly pernicious for them was that many women took a great deal of pride when they moved into employer-provided insurance. They got a job, they could get insurance from the employer, but without protection for the job itself. A very common scenario was that the women got sick, were out of work long enough that they got fired, and with the firing went the health insurance. That was what they were being treated through. So in these kinds of conditions, what did families do? They made tough decisions. Sometime I'll tell you the long explanation of how I and most of the mothers I knew in that community made what I considered the totally rational decision to feed our children primarily Kool-Aid through the entire summer. Dentists hated us, but we had to keep our children hydrated under a lot of different pressures. I can come back to that. We found that they went without or delayed health care. We watched one woman agonizing over the decision of whether or not to have a hysterectomy since she was bleeding almost continuously. But she wasn't sure whether it would get paid for. She wasn't sure who could care for her children when she was in the hospital. She wasn't sure the hospital would do when it became clear she didn't have any facilities for aftercare. These families also had very little access to preventive care. So although children could get well visits, the capacity to deliver them in this very densely populated community was limited. So both children and adults were doing without a lot of screenings, and important groups, immigrant groups, other groups, were not eligible for screening. And so this again contributed to the spread of tuberculosis and to the presence of other kinds of problems. They went into debt. Many of the families had debt that was incurred for particular health problems, but also for over-the-counter goods, trying to keep stocked with diabetes strips, trying to keep stocked with dehumidifying equipment, if that's what your children needed, were induced debt in families. Families taken by surprise by medical emergencies could end up with tens of thousands of dollars of debt. And they only treated acute problems in many cases. They also engaged in informal trades. There was a lively informal swapping network of overdue and not unused prescription drugs where families would self-diagnose and trade drugs. With this kind of background, what can we do? We need to look very seriously at all the elements of more universal care, which these families and children need, and it looks like we're working towards. We need to think about ways in which we can use the Affordable Care Act and other resources to deliver public health and community-based health as well as individual services. We need to realize that health policy is also housing policy, jobs policy, nutrition policy. You can't have good health policy without engaging in the others. And following again on Heidi's presentation earlier, recognize the value of the programs we have, Medicaid, S-CHIP, Medicare, cash transfers in health, and look at the at the Affordable Care Act, which I'm trying to do myself right now, with an eagle eye for the opportunities to engage across all of those issues in this next round of health care.
I'd now like to introduce Dr. Jane Delgado, President and Chief Executive Officer of the National Alliance for Hispanic Health, Innovation, and Action. I'm sorry, missed my punctuation mark there, bear with me. Anyway, innovation and action have marked Dr. Delgado's career, and she's recognized as a leader who is transforming health and health care in this country. So please welcome.
I'm not texting anyone. I'm just timing myself so that I stay on, because really, for this group, I wanted to do something that you can take with you. So my assistant is out there passing out my PowerPoint. I use that mostly as backdrop. So we're going to, I hope, is this it?
Yes.
Yes, okay, so, all right, I'm going to start now. So you need to know something about me and where I work, and I think that's important. Oh, that one, okay, there we go. So this is the National Alliance for Hispanic Health. You know, we're a very special organization. We don't take money from tobacco or alcohol or lots of other people. So right now, the soda people don't like us very much either. And after I speak to you about CVS today, they're not going to like us very much either, too. So that's true. This is our major assets, our people, our operations, our values. We at the Alliance don't talk about health disparities. I know that's, a trade name, people use it. We actually talk about best health outcomes for all. And the reason we say that is because we want everyone's health to be better. We have members from national organizations to individuals. We have great governance. A lot of organizations come and talk to you, but you should know that in terms of governance, we really do have a lot of stellar things, even the silver bicycle-friendly business. These are the kinds of things we do. We have helplines. We have Get Up, Get Moving, a club. We have veterans. We have work on Alzheimer's. We give out $450,000. That's not $450. $450,000 in scholarships annually. So that's some of the things we do. We have a foundation. And when I talk, I want you to just have some caveats. First of all, when I talk about Hispanics, people often say, well, Hispanics are so diverse. All people are diverse. Non-Hispanic whites are diverse. They all came from different countries, But, we also speak in a core Spanish language, and that's the broadcast Spanish. And people say, highly value family, loyalty, education, speaking English, and respect. These things are really important to us. I know everyone says, well, that's important to us. There's nothing like Hispanic guilt, trust me. I know. The next is the process of inclusion is very important, how we got here. If we were immigrants, refugees, undocumented, or acquired. What is acquired? That's the West, Southwest, and Puerto Rico. So, just to give you a different flavor on things. Okay, cultural context. Culture is king. And I think we sometimes miss that. Look at our society, this health milestones for all when we talk about health. These are milestones that affect women, race and ethnic groups, and that means it's 2/3 of the population. But look at these dates of when things happen, and you can go on, 1985, PHS issues report on women's health. Women didn't arrive in 1985, but that's when our report arrived. FDA publishes that rules that require data by race ethnicity. That's great, but in the Affordable Care Act, I can tell you my staff was up on the Hill fighting to make sure that the electronic health record included data on race, ethnicity, and gender. The gender fight was the biggest one. And that continues to be a major fight. I'm sure that Phyllis, who's one of our longtime champions, will talk more about that. Culture. People talk about cultural competence. Forget it. It should be cultural proficiency. This thing is not bilingual. I'm on an Apple platform. This is not an Apple platform. So cultural proficiency, so that's wrong. It should be together. This society thinks cultural blindness is good. And that's wrong. We need to celebrate people's culture. We need to know people are different. This is okay. And, and we want to work with whoever they are. Meet people where they're at. I'm a clinician too. And that was their lesson number one, as was said before. You meet people where they're at. Not where you're at, but where they're at. That's harder for some people to do. Okay, just so you have a quick history, you have when Hispanics arrived, 1494, blah, 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 all the way down. Remember, English is one of the last languages to arrive on this continent. Okay, communication in the U.S., monolingualism is the norm. Speaking another language is not valued. And there's a lack of understanding of what it takes to comprehend, to speak, or to write another language. The speaker who said English is her fourth language, I resonated with that. I have a friend who has a very heavy accent when she speaks, and she says, English is my third language. My father thought I should learn French and German. French, German, and Spanish first before I learned it's a fourth language before. So it was like, and listening is a lost art. So commonly repeated things which are implied, assumed, and wrong. Hispanics are a small part of the population. Hispanic growth is due to immigration. Immigrants are unhealthy. All people with excess weight are less healthy. All minorities have poor health. And your genes tell the whole story of your health. All these are wrong, but you hear them all the time. So, here's some key facts that may surprise you from my wonderful executive staff. First, Hispanics are 1 in 6 in every people in the United States. even if you took every undocumented person in this country and said they were all Hispanic, which is not true, our numbers would still be larger than the African American population. And I say that only because people don't think of Hispanics as a large population. They understand that the African American population is large. They may not do very much about that in terms of being helpful or providing good health, but they think that way. But we're 1 in 6. Composition of U.S. population, we're growing because of births. Okay, percentage without insurance, we've always been high. How come? Even when a lot of us live in Texas, like Laura said. And what are the problems with Texas? Texas has the worst programs. Is anyone here from Texas? Okay. When it comes to providing health coverage to people. That in order, in other states you can get Medicaid. This includes people who don't even have public health insurance. And if you're in Texas, you can't even get that. It's very hard. We're poor, that's true. And of course, women are even more poor. This is where I start to want you to rethink things because, in fact, one of the problems we have is how people view people. Right now, we have a situation where with, obesity, everyone's talking about it. But really, if you look at the data from CDC, what they find is that if you're overweight, or even now they have things on obese level 1, that you actually have fewer deaths than normal weight, and much fewer than underweight. But there's a whole industry that is about, getting people to be skinny, and as every woman in America knows, she's overweight. They thought that those data were because people who were sick got underweight, but actually it's not. It's actually, when she had to do a reanalysis, because they said, oh, well, that couldn't be. How could all those fat people live, and be okay? In fact, we don't understand things. And more we're learning that the fat in your body is part of your endocrine system, and how it works really varies. And we need to understand a lot more than what we do now. So, what do we know? Everyone knows Hispanics are overweight. This is not new news. I don't want to bore you with a slide on that. What did surprise me is that we had less heart disease. Okay? Considerably less in non-Hispanic whites and considerably less in non-Hispanic blacks. And of course, this was a real important question when I used to ask it. Why do Hispanics live longer, blah, blah, blah? Why do we have less heart disease? But it didn't matter until Betsy Nabel, who was head of the National Heart, Lung, and Blood Institute, actually asked the question. And she was curious enough to kick off a big study. Now, when I first presented these data on projected life expectancy, people thought that I was making it up. I have better things to do. I want to write fiction. It'll be a romance. 50 Shades, move over. But here, projected life expectancy. So we got to read up on this. I actually ended up with Diane Sawyer's program at night because when CDC came out with their actual life expectancy, they found that we did live longer. Now, how can poor people who have no insurance, no access, actually live longer? My cynical friends used to say, well, that's because you don't see doctors, ha ha ha. That's really a good science question for everyone because it's not a genetic difference. What happens as we adopt more of the North American lifestyle, we start losing those good health outcomes. This is a concern. Going into cancer, we also find that the highest cancer rates are really in 2 groups, non-Hispanic white females and black men. The black man has to do with smoking tools, so anything that you can do to get men not to smoke, cigarettes, and prostate cancer. And there's, more data about this, and it's mostly driven, if you look at the lung cancer rate for African American males, look at that, 102.7. That is much higher than anyone else. And also prostate cancer among men. So that really drives a lot of the combined African American data. But it also says we need data by gender and by race, ethnicity, so we can understand what's going on in different communities. Because it concerns me that we do very little on some cancers that are much higher in the Asian Pacific Islander community. Now, I only present data for where I have data. If I don't have it, it's because whoever but that's besides the point. Now, the Affordable Care Act, how do I see it? It's a step in the right direction, but we still have a long, long way to go. And the reason is because I don't think people are speaking with one voice. So, for example, the president says undocumented youth can be granted lawful work authorization. DHHS says they cannot be part of the Affordable Care Act. They can't go to the exchanges, they can't buy anything like that. Everybody recognizes the importance of long-term care. It's part of the Affordable Care Act. HHS was supposed to develop something. They said, oh, it is too complex. We can't develop something there. The third thing, ACA said, and I was out there talking about it, saying, we're going to help poor families buy health insurance by giving them a tax credit. Look, that's not a solution, but I was happy with something. The IRS just came out with a ruling. Well, we're going to help those people if it's more than 10% of their income, but we're only going to look at the cost of the individual policy. So if you're paying for a family policy, that doesn't count. They're not going to look at those costs as 10%. So to me, that's great Affordable Care Act intent, but the agencies are interpreted in ways that are very hurtful to poor people, especially poor women. And the long-term care issue, that's a women's issue. And a poor woman's issue. Don't let anyone allow us to walk away from that. Not just because we're caregivers, because they are us, and we are them. It's all one thing. And finally, one of the major problems is we really lack a lot of good science about the individual. And one of the things I talk about is I am tired about the Hispanic paradox. That's what they call it when they say Hispanics, are fat, poor, they live longer. It's a paradox. Now CDC, I was down there, they have the obesity paradox. How can people who are fat actually have better health outcomes? Well, because you really need to segment it by age, and when you're older, you may need to have a little more on you than when you're younger. That may be the truth, but it's the activities you do, what you eat. There are a lot of things much more complicated than just what you wear in the scale. And then, I hate paradoxes, because paradox means you're a lazy scientist. Going on, back to the 1899 Merck Manual, look what we used to prescribe to people. Arsenic for diabetes, cannabis, I know what that is, for insomnia. Smoking tobacco for asthma. No wonder people didn't live that long. So, moving on, people thought the answer is in genes. It's not. It's genes and epigenomics. It's, you have a gene, but what turns it on and off? We who work in communities understand that there are different things that turn things on and off. In the last 2 years, the whole thing about the microbiome, the bacteria that live all around us, all these antibacterial soap and all this other stuff may actually be doing more harm than good. I'm just doing my time check. I have 3.5 more minutes, so this is going to speed up even more. Major problem when it comes to poor women is this concept of endocrine disruptors. Because while if you have more income, you have the possibility of not using certain products, other women do not. And it's a real problem because most endocrine disruptors work the way hormones do and not like toxins, which means you need a tiny little bit to make a huge change. This is a huge change that just happened this past December. All of a sudden, 25,000 tons of herring floated to the top in Iceland. They called it fish kill. When I grew up, fish kill was not part of the vocabulary. Going on, what does this have to do with specifically Hispanic and African American girls? Look at what's happening in terms of early sexual development, in terms of breast development in girls. NHB is non-Hispanic black, NHW is non-Hispanic white, Hispanic is Hispanic. 8-year-old girls, 43% of non-Hispanic black, 31% of Hispanic girls are developing breasts now. And this was a study that was done in Cincinnati, East Harlem, and San Francisco. So this tells you that those endocrine disruptors, here we go. Here's some outcomes we have to be concerned about. All right, and of course, EPA, my favorite thing, and all of us should love this. A lot of their cancer risk from radiation is based on reference, man. It's time to get rid of reference, man. This 5'7", 154-pound man who is Western European of North American and habitat in custom. Now, this is not good. Because specifically, women and children have other biology. So, this also studies, the study that just came out, the IOM report on obesity prevention. I was shocked. The very first thing they said, genetic or biological factors are not going to be considered in this report. Okay. And then corn syrup appears 3 times, but sugar sweetened is a lot. And the whole thing with obesity is that really your basic scientists are looking at it and saying, is it a causal factor, a correlate, or a consequence, or different things at different times? And that, I think, is going to be the last one, which is hard. And the benefits of exercise vary. This was a very important study that just came out that showed that for African American girls, it was a prospective study. Give them the same level of exercise and did not have the same level of outcome. So, sound popular, sound bites, but sounds good, but misleading. And these are a whole bunch of them, everything from you spend most of your healthcare dollars in the last months of your life. Gail Walensky, who some of you may know, is a great health economist, and one of my board members says, don't let people say that. Because it should be, you spend most of your Medicare healthcare dollars in the last months of your life. Because people don't know what you're spending your whole life. Think about it. How would they know? So the whole thing about comparative effectiveness research, outcomes research, evidence-based medicine, that's great, but there's not enough data on women. There's not enough data on women by race and ethnicity. So, is this the care you want? The case on the first is a friend of mine I was taking care of, and they wrote, she only drinks from a cup. She's not that she only drinks from a cup. She was so weak she could only lift a cup. That was why. The other thing was a case where my friend went into the hospital with his hand okay. All of a sudden whoops, there's my timer. All of a sudden his hand got worse. It took 6 days before a doctor decided that they should do something about that. It went from a normal hand to that. So, solutions, issues of older adults should be a focus for all women. We need to focus on high tech and high touch at the point of care. And the last thing is the focus on the individual must include genes, epigenetics, the microbiome, and the environment. And as social workers and as clinicians, we have the ability to really pull together the pieces that other people cannot. Thank you.
Next, we'll hear from Phyllis Greenberger, who is President and CEO of the Society for Women's Health Research, a national nonprofit organization based here in Washington, D.C., who is widely recognized as a thought leader in women's health research. Thank you.
Well, good afternoon. I'm delighted to be here, and I guess if you looked at the bio inside, you'll see that I'm a recovering social worker. While I don't practice it, I do think that having that experience and that education helps in all aspects of life. So as was mentioned, I'm the president of the Society. We're a nonprofit advocacy organization that's responsible actually for breaking down the barriers that existed for women being included in clinical trials and changing biomedical science and creating and transforming the science of sex differences. I'm going to take credit for some of the things that Jane said, and I think she'll nod. The Congress did not figure out on its own in 1990 that women needed to be included in clinical trials. It was the Society for Women's Health Research. Those of you who work with Congress know they don't really figure out much on their own. They need you to come and tell them that there's a problem here. So we worked with Congress, actually Pat Schroeder and Olympia Snow at the time, both of them in the House, and got that GAO report to investigate the National Institutes of Health to see whether women and minorities were included in clinical trials. And of course the answer was no. So we know now, of course, that and as Jane said, the prototype for clinical trials was usually a young, white, healthy male. And the reason for that is that people thought, doctors, researchers, clinicians, that male and females were essentially the same except for their reproductive biology, and other reasons having to do with the fact that we're more complicated. We have hormonal cycles, we get pregnant. In those days, not like now, where you can find out almost immediately if you're pregnant or not. In those days, the rabbit mentioned, and we do know now that men and women are different genetically, hormonally, environmentally, and physiologically, and that needs to be taken we need to consider that, and that has an implication for the onset of disease, the severity, and the types of diseases that we get. So we now know a lot more about diseases and illnesses that predominantly or disproportionately and exclusively impact women and minorities. What we don't know in many cases is why. Now, what we're talking about today, obviously, is the feminization of poverty. So what hasn't really changed, and in fact, when you read the newspaper and listen to the news now, if anything, it's getting worse, the level of poverty in this country. So the status of women as in this society and the status of women in poverty is continuing to go down since, of course, 2008. And there are complicated issues surrounding the health care of poor, underserved women, some of which Jane mentioned. There is a dynamic between poverty and poor health. Many conditions can result from poverty, which was mentioned earlier, and they can also escalate to more serious stages in the absence of appropriate health care and also health literacy. You need to know what you need to know about taking care of yourself, the questions to ask, symptoms that you might have, and if you're poor and uneducated or you don't have access or time, that's that much more difficult, if not impossible. Poor women comprise a disproportionate share of healthcare consumers for obvious reasons and often manage multiple chronic conditions. And with the Affordable Care Act, of course, we still don't know what's going to happen in a lot of the states in terms of Medicaid, how many of the states are going to accept and how many are not. But then there's a slice of people, both men and women, of course, that fall in between the cracks, that are poor enough for Medicaid, but don't have enough money to have health insurance. So even if Medicaid is expanded, you're still going to have that problem. Now, I do agree with Jane on one level, but not necessarily on the other. I read the research about a little bit of fat is good and keeps you healthy. The problem is how you get that fat. It's funny because in the Middle Ages, the heavier you were, the wealthier you were, if you remember, King Henry VIII. But nowadays, that's not so good. And the problem is that poor people don't have the access to healthy, nutrient food. So they're surrounded by fast food and places, 7-Elevens and stuff like that. They don't have the transportation and the time, especially if they're single mothers and they've got and working maybe even 2 jobs to get healthy food. So they eat a lot of packaged food. Now, I don't know how many of you, there's been a lot of focus now on unhealthy eating. A couple of books just came out. There was a big article in the New York Times about 2 weeks ago that was frightening, looking at some of the foods that we actually think are healthy and what's actually in them. So processed food, generally speaking, I think is a no. And for people who are in poverty and who don't have access to good food and don't have the money to buy them, they're eating a lot of junk and a lot of additives and a lot of ingredients that they shouldn't be eating, and that's not healthy. And that does lead to obesity, which can lead to diabetes, of course, and cardiovascular disease. And as I said, the lack of shopping options in the poor neighborhoods. Now, one of the things, and actually the society, again, was, as I said, responsible for the GAO report to get women included in clinical trials at the NIH and the FDA. I must say we still work on that every day. It's not a problem solved. It's a lot better, but there's still a lot of issues. And one of the main issues is we can talk about prevalence, and we can see statistics, but we still don't know the why in a lot of cases. We know that women's symptoms are different in heart attacks. We know that women have greater, die more from atrial fibrillation. We know that they have a more propensity to have a second heart attack after the first one. And we know that they have a higher mortality rate. They do get heart attacks later than men. And I will also take credit for my organizations pointing out that women do get heart attacks. Up until about 10 years ago, it was a man's disease. Well, we know now it's not a man's disease. It kills more than 50,000 more women a year than men. So we now know that the symptoms are different. We know that some stress tests don't work. We know that stents work differently. We know that there are certain kinds of cardiovascular disease that are more prevalent in women, but we don't know why. So that is an area that, even though both men and women, poor and wealthy, women suffer from, the sex difference, and as Jane said, there is a difference in Hispanics in terms of cardiovascular disease, but nobody knows why, right?
No, but
Right.
they're finding out.
Okay, they're finding out. Hold on. So what we do know best really is prevalence. And then of course diabetes, which I mentioned, at least 1 in 4 women with diabetes, 25 and older, have a low level of education, and 40% live in low-income households. And they're more likely, obviously, to have a low socioeconomic status independent of living arrangements. Now, there's probably not anybody in this room, especially since I assume you're all social workers, that don't know that men and women's brains are different. My 10-year-old granddaughter told me that boys were crazy, and I said, well, you got a point there. And I think you learn at a very early age that girls and boys and men and women are different. But it's not just functionally, it's structurally. And this we're finding out as technology, of course, got better and better. We can actually see the inside of brains. We know that these differences can result in different rates of neurological disorders in men and women. For example, women have higher rates of depression and anxiety, which I'm sure you know, while men have higher rates of autism and ADHD. And then, of course, there's postpartum depression, which a large percent of women, and this often goes undiagnosed, of course, between 10 and 15% of women in low-income minority women especially, and that I would imagine is to some extent because of their living conditions generally, because they're not spoken to while they're pregnant about the possibility, and they're not given care after the fact. Cancer. Women have a higher risk for a number of diseases, including osteoporosis. Osteoporosis, it's about 8 to 1. There are differences in bone structure. We're doing a lot of work actually looking at sex differences in muscular and arthritis and diseases that have to do with osteoporosis and osteoarthritis. Lung cancer is the leading cause of death for women, more than breast, cervical, and ovarian cancer. And actually, for a long time, the numbers of smoking actually in men have gone down, but in women have gone up. And now, I actually was at a meeting not too long ago at Legacy, which is the organization that promotes advocacy against smoking. And you may know this, I didn't know this. My kids are older. They have all these newfangled kind of cigarettes that actually are much worse than the regular cigarettes that are apparently very cool in college now. Yeah. Then, of course, there's autoimmune diseases. At least 75% of autoimmune diseases affect women. In some cases, like lupus, 8 to 1. Autoimmune diseases, there are over 200 autoimmune diseases, and they have very sort of vague symptoms, pains, aches, tiredness. Even with wealthy, well-educated women, it can take 5 to 7 years to get a right diagnosis for an autoimmune condition. So you can imagine in poor communities, women suffering from these conditions who don't have the internet to Google or don't have friends to talk to or don't understand what's going on or just think it's because they're poor, depressed, and everything else that is something they have to live with. And so it's very difficult. I actually can suffer from one myself, luckily not that badly, and I diagnosed it myself when my doctor didn't, and I gave good care, so I can tell you. Addiction is another issue that obviously affects low socioeconomic individuals. Interestingly, women are more easily addicted and have more trouble stopping. We did some research looking at alcohol that used to believe that men and women, that the reason why women got inebriated more than men was because they were short of stature and weighed less. And now we know that actually they get inebriated faster because they metabolize differently. It has nothing to do with their weight and their height. So, you know, there are a lot of issues that I did not get into, like HIV/AIDS, allergies, asthma, which can arise, obviously, which was spoken about earlier from environmental conditions. I want to say that, you know, we have been working on looking at sex differences. We meet with the FDA and the NIH constantly. There's no question that more women and minorities are in clinical trials, but you need to be in clinical trials, and you need to tell the people that you work with, we're not going to have the answers if more women and minorities are not in clinical trials. That's where we get the information from, and that's what we need. We also need companies to do sex analysis, and they're not. They're including women in clinical trials, but they're not analyzing the sex differences. We actually were having lunch a little earlier today with a company and a young woman who worked at another company previously. We were talking about, you may have seen this, the sex differences in sleep medication that came up, and we've been talking to the FDA about looking at differences in medication for years now. They finally got one, and it turns out that this woman that was at lunch with us worked for the company that had the sleep medication that they just came out with that, and she said they knew that, the company knew that, but they didn't do anything because that would have, you know, that would have resulted in selling fewer drugs. So now, I don't want to do, I mean, we get support from pharmaceutical industry, we support them, we support their work, but there's work that has to be done. And as far as the NIH, one of our concerns, or major concern, is that while they're looking at phase 3 trials, they're not looking at phase 1 and basic research. And we, by the way, have a international organization for the study of sex differences, which is basic research. So I could go on, but I won't. I think you've got the picture. So I think it's not just the feminization of poverty, but there's also been a feminization of healthcare for women. We're starting to change that. We work on that every day, and I hope that you'll join us in this need for awareness and advocacy and congressional action regarding these serious health and healthcare consequences affecting all women, not just poor women, but all of us. And if I might, we would love for you to come to our website. We have a newsletter that goes out twice a month on the latest research in women's health, covers everything. If you're interested, and it's www.swhr.org. I really appreciate your attention. Thank you very much.
Finally, we will hear from tribal health advocate, nurse, and former president of the Oglala Sioux tribe, Ms. Cecilia Firethunder. Ms. Firethunder has advocated relentlessly for greater access to women's health care within, and health care in general, within tribal communities. Thank you for being here today.
My relatives agreed with the word handshake. This picture is the woman, you can barely see her. That's my auntie. She's dying right now. And she got kidney failure. So I told her, hurry up and come back. Next to her is Wilma Mankiller. And Wilma passed away in the last 2 years as well. This picture was taken at my inauguration when I was chosen to be the president of my nation. The first woman in 69 years. And I just wanted to tell you that I'm a pipe carrier, I'm a sun dancer, and I practice the old ways. I'm a recovered Catholic. I feel like I didn't need to go into confession. But I tell my friends, well, all those years being a Catholic, I might just have a little extra push to get into the other side. I also want to comment on voluptuous women. I feel like, I'm 66, and I'm not diabetic. I don't have high blood pressure. There's nothing really wrong with me except my bladder is not behaving properly. So a lot of Indian women, American Indian women, are pleasingly plump as well. So So I always tell Indian women, you girls are not fat. Don't ever let anybody tell you you're fat. All the bread, tortillas, and crackers, and donuts you eat, you're just full of dough. So anyway, where's the clicker here? So today I wanted to remember, this one? Okay, I just wanted to remember Wilma, and just wanted to let you know that our role models are all the women in our community. How many of you know that? These are the women who have led the way. They showed us by example. And so I just wanted to remember Wilma today and my auntie. Okay? Yeah, we love her. I love this picture. This picture is, see that woman? She's in the trunk of a tree. And what this picture conveys to me is that the American Indian women are rooted to this country. How many of you believe that? I mean, you're all visitors. and so in Lakota we say huta. Huta is root. Nitueke huta ke mahetia. Generation after generation, all those who went before you are part of who you are. So you can never, ever forget who you are. How many believe that? So our roots are deep, and as Native women, we have deep roots in all parts of the United States. And part of our healing is to capture the teachings of the past. Talk to your mother, your grandmother. Talk to all those who know more than you and follow their advice, and you will be a healthier person. Who am I? Maduehe. I learned to speak English when I was 5 years of age. I spoke Lakota up to then. Then they put me in a Catholic boarding school, so I learned how to say Our Father first. And Hail Mary. So in my culture and my language, and before I go any further, Teresa, thank you. Thank you for reminding us here in America how privileged we are. Is that true? Yes. When I look at the condition of women around the world, I say, do not be bitching around. Get your ass out there and do something about it. We cannot, and we are privileged, ladies, we are. So, who am I? Maduehe. In Lakota, we say, Niduehe. Who are you? We never say you have a PhD. Oh, by the way, I do have an MSW. I forgot to put it on my thing. However, it does not mean master of the social work. I'm a magnificent Sioux woman. So in my culture, when a woman becomes pregnant, iglush aka. Where was iglush aka handa? We don't become a medical record. Pregnancy is a time when a woman becomes stronger. Yeah? So she strengthens herself. Well, and during the 8-9 months that I was inside my mother, her and my father looked for somebody of character. In our culture, we have somebody come in at the time of delivery and be the first one to touch you as you come out of the birth canal. A person of good character. That person who touches your fontanelle, we say, lewi wila, that fontanelle, and they touch that, her spirit goes into you and strengthens your spirit so you come completely out of the birth canal with extra vigor and energy. Is that cool? Yes. And then so the placenta is sacred. In my culture, that placenta is treated with tremendous amount of respect. That placenta is tied to the top of a tree if you're somewhere where there's no place to, if you tie it to the top of the tree, and you pray and ask the thunder beings to come get you. So they take you back into the universe and all the ancestors know who you are. If there's no tree, we bury you and we give you back to the earth mother. The placenta goes back to the earth and all the female ancestors know who you are. That way when you get ready to go to the other side, they'll say, come on over. And they don't bury your placenta, you have to stay in Washington, D.C. they cleaned your mouth up. Heche wichoni wa yachukte. Your life began as soon as you came out of your mother and you breathed on your own. So in my culture, we say, wichoni egignate. That means somebody died. You set aside your breath of life. So she said, when I took my breath, then I was a human being. Up to that time, I was on a support system with the umbilical cord, right? You bet. Are Indians smart or what? We're really smart. We figured this out before the scientists did, okay? I only spoke Lakota until I was 5, but my Ina also said, in those first 3 minutes, I looked at you. I told you who you were. Your mother, your father, your grandmother. I went back as far as I could. And so those first 3 minutes, you knew who you were. That's the roots, is it not? Catholic boarding school for 10 years. Oh my gosh, I must be Father, for I have sinned. My last confession was 7 weeks ago. Did you sin, my child? No, Father. What do you mean you didn't sin? How can an Indian girl out in the middle of the prairie sin? Anyway, in 1963, I relocated where my father was a cowboy, tall, good-looking Indian man. And we raised cattle. We lived out in the country. We lived off the land. We grew our own food. We butchered our own cows. It got really hard, so my father decided to take us to Los Angeles. In 1963, we arrived in LA. Hollywood, California. Oh, what an exciting time. 63 to 1975, I lived in LA. I became a single mother. I went to nursing school, and I started working with women of color. And doggone it, they taught me well. Organizing, started a free clinic in Compton, California, because health insurance was not attainable for a lot of our Indian people because they got low-paying jobs. They had no health insurance. So the free clinic movement started. So we started a free clinic in Compton, California for the Indian people. Is that cool or what? And then I got involved in a research study. I didn't know anything about research. How about you? First time they asked you to do something, you say, sure, I'll do it. You said, what is this? So anyway, I did it. So we did a study of Indians living in the San Antonio Health District in the county of Los Angeles. And that data sustained that community. I moved to San Diego. Lived in San Diego until 1975. I started an Indian clinic in San Diego County. It's still operating, called American Indian Health Center. Is that cool or what? And then I went in 1986. Now this is really important. I have absolutely no control over what I do. You know why? Because the Spirit guided me. How many of you believe that? How many of you have the Spirit guide you? Yes. I pray and I say, oh, please help me. I go to sleep and I say, I'm asleep and I want you to come and talk to me. So my life is guided by prayer, by ceremony, and by spirits. Yeah? Is that cool or what? So when I decided to run for the presidency of my tribe, I went on a vision quest. You probably read about these in books, right? I went up on the hill out in the wilderness for 2 days and 2 nights. And in those 2 days and 2 nights, in our ceremony ways, we prayed, and I asked, the only thing I wanted to know was the grandfathers that went before me. I needed their permission to run for the presidency of my tribe. And they said, yes, my girl, but it's going to be hard. It's going to be hard, but we'll be here for you. So what I wanted to convey to you was this, that in all the work that we do, it really doesn't matter because sometimes you're chosen to do it. How many of you believe that? You can have a PhD, you can have a master's degree, but that's not your calling. The spirits call you. How many of you believe that? Yeah, there's a calling that you have. This is the Aberdeen area. This is North Dakota, South Dakota, Nebraska, and Iowa. In North Dakota, these are the Indian tribes. In South Dakota, to your left, is my reservation. 2.6 million acres of land. That's a lot of land, isn't it? Yeah, we got a lot of horses and cows. We have ribeyes. Woo! We have what we call walking hamburger. We actually have really good beef because it's what they call range-fed beef. So My reservation has 40,000 people, roughly half are 18 and under. I'm not going to even go into all of the statistics because we know that Pine Ridge is the third poorest county in South Dakota. Cheyenne River took #1. We said, hey, finally, we're not #1 anymore. I also want you to know, this is a really important piece of information. Shannon County, where the Pine Ridge Indian Reservation sits, was #1 in the most people who voted for Barack Obama. So I got that statistic. I said, oh my God, you guys, you did a good job. So finally, I'm going to just move into this real quick. American Indians, my people, are the only ones mentioned in the Constitution of the United States under Article 6. Article 6 of the Constitution says that treaties are the supreme law of the land. In the 1868 Fort Laramie Treaty, Article 13, that's the treaty that my people signed. In all the provisions in our treaties, this is what it says. The United States agrees to furnish annually to the Indians the physician, teacher, carpenter, miller, engineer, etc. This is the basis of our relationship with the United States government. The physician means Indian Health Service. The teacher means education, okay? That's our 1868 treaty. The other actions that were taken outside of treaties were settlements, agreement, executive orders, and legislation. And right now, today, in the last 20 years, there's been a lot of new federally recognized tribes. So our tribes are very big or very small. This picture, it tells you the history of our health care. So from the 1860s, the treaties, I looked at the Kiowa treaties, a variety of other treaties, and they all say the same thing, health care. And then in 1926 was the first time any language was put in legislation to provide for health care for Indians in the United States. And in 1955, the Transfer Act. So the business of taking care of the health care of Indians went from the Bureau of Indian Affairs to the Department of Health and Human Services. And of course, the Social Security Act that created Medicare, Medicaid, PL 93, 638, which is a very important piece of legislation for Indian country that allowed Indian tribes to manage their own programs. For example, I represent 7 schools on my reservation. Those 6 schools are local control. We have our own board of directors. And so those were some of the first steps to taking local control, taking ownership of our destiny. Indian Healthcare Improvement Act in 1963 was the first one, and then they just reauthorized it in 2011. So to tell you how long I've been around, I was up here on the Hill in 1964, I think, was the Indian Healthcare Improvement Act. Isn't that great or what? Anyway, since Snyder Act, I talked about it, the Transfer Act of 1954 moved it from the Bureau to the HHS. However, the appropriation for IHS still comes out of Interior budget, not HHS. So in 1955 to 1975, Indian Health Service was the only healthcare provider for all the tribes of the United States. After the Indian Self-Determination Education Assistance Act, which allowed for tribes and organizations to start managing their own clinics, things changed. Now, Senator James Averest, I don't know how many of you remember Senator James Averest. He is a senator from South Dakota. He's a really jolly fellow. He's my friend. We visit a lot. When Senator Averest was elected as a senator from South Dakota, he went from being a congressman to a senator. He immediately started to put together the Senate Select Committee on Indian Affairs because there were so many Indian issues that went nowhere. So the Senate committee then created the Permanent Committee on Indian Affairs. So today we have tribal programs working hand in hand with IHS, and finally, here we go. Finally, the treaty with the United States government, all the agencies within HHS, every one of these agencies has a Native American advisory board, finally. Okay, so here's the final picture. Pretty picture, isn't it? So this is the Indian Health Service. 12 areas. California, Navajo, Albuquerque, Tucson, Oklahoma. I'm in the Aberdeen area, the purple one, about 135,000 Indians amongst all the 19 tribes. And Navajo has the largest. Navajo area has their own area. They have about 250,000 Navajos. Is that cool or what? Hey, I think it's wonderful. So anyway, with that, many changes. We have 12 tribal epidemiology centers. We do a lot of research, work with the state government, tap into their system and share data information. We have 30 tribal colleges. These 30 tribal colleges have nursing programs, a variety of programs, helping people get skills so they can be employed. We have recently got a lot of good transportation system. My tribe, my cousin wrote grants. We have buses going all over the reservation. North Dakota, South Dakota, this is another picture. We meet quarterly with state Medicaid. And then that way we're on top of Medicaid issues. With our tribal radio station, community education, finally, we are working very hard with our K-5 schools to strengthen their math and science programs so we can prepare our kids to be doctors, nurses, and that sort of thing. Anyway, thank you. Oh, wait, one more thing. You have to see this one. All right. I want to acknowledge all my sisters who are out there in the front lines fighting the fracking, sand tar oil, and clean water. Listen to this. And so